Thank you, Ashay sir, for giving me this opportunity. So let's look at the ACL graft options and biomechanics. We all know that the ACL is generally composed of two bundles, the anteromedial bundle and the posterolateral bundle. The anteromedial, this nomenclature is based on the tibial attachment. So the anteromedial is attached anteromedially on the tibial surface. The posterolateral is attached posterolaterally on the tibial surface. So if you see the first diagram, it is in extension. So the anteromedial bundle is anterior on the femoral side also in extension. But the main confusing part when we put our scope inside is during flexion, where the posterolateral bundle is anterior on the femoral side. So in 90 degrees of flexion, there is a twisting of the bundles where the posterolateral comes anteriorly. So this is the main confusing part where we need to know which is which bundle and which bundle we are going to reconstruct and what are the functions of each bundle. So, but in the recent times, Smigelski has done some wonderful work on the shape of the ACL. And it is generally accepted now that instead of these tubular structures, ACL is basically like a flat ribbon. So the bundles are still there, but the shape is not like a cylinder or tubular. That's why newer and newer techniques, including our own Ladda sir's technique of a rectangular tunnel. So that helps in recreating this tubular shape. So what is the function of the ACL? We all know that ACL helps in preventing the anterior tibial translation, but it also helps in the rotatory stability. It prevents internal rotation of the tibia. So if we plot the stress strain graph, if we see which bundles has most stress, we all know that the posterolateral bundle is more active in extension. If we see the graph, the green one, the red one is the posterolateral bundle. Maximum strain is in the extension. And if you see the green plot of the anteromedial bundle, it prevents the anterior translation on the flexion part, okay? So the functions of the bundles are different in each flexion angle. The same goes with the center of axis of rotation. So in an intact ACL, the center of axis goes through the center line of the tibial plateau. However, when the ACL is deficient in chronic ACL deficient cases, this center of axis is shifted medially. So what this does is it causes increase in contact forces on the lateral side. Every contact force on the tibial plateau is shifted on the lateral side. So in chronically deficient patients, we generally notice a lateral side pain or a lateral patellofemoral joint pain. And the reason for this is the center of axis is shifted medially. This is a very interesting concept which I think every clinician should know. What is the center of gravity? So if we see the top two diagrams, that shows the joint, the dotted line is the joint reaction force. So what it signifies is when the knee is flexed, the center of gravity and the joint reaction force is on the posterior side. When the knee is extended, the joint reaction force is on the anterior side. So suppose the center of gravity is on the posterior side. To compensate for that, the quadriceps muscle has to act. If the joint reaction force is on the anterior side, to compensate for that, the posterior muscles and hamstrings have to act. If they don't act, we'll fall. So if we see the stance phase, so the lower diagram is for the stance phase. So there's a heel strike, there is a mid stance and the toe off phase, 1, 2, 3. So if we see, whenever in the position 2, in the mid stance phase, the knee is in flexion around 20 degrees. So that's where the quadriceps and ACL have to act. And when the ACL is deficient, this function is lost. So there is a chronic quadriceps weakness in the mid-stance phase. That's why we see so much of quadriceps atrophy in ACL deficient patients. And the reason for this is the quadriceps force is lost in this mid-stance phase. The same can be seen here. The ACL forces are maximum in the mid-stance phase at 20 degrees of flexion. This is again a very important concept which is which is often overlooked. We neglect this theoretical aspect, but it is very important for our clinical scenarios also. So this is nothing but the force length or stress strain graph. That means how much force is applied to an ACL ligament and how much fiber length changes. So if we see that maximum portion, the ACL is slack. However, in a narrow range, there is a force increase happens. And once the force reaches up to a threshold, after that it fails. The same plot is magnified here. Generally we see these stress strain graphs. And the slope of the curve is nothing but the stiffness that we see, that we calculate. That is the elastic modulus. So if the graph is too vertical, it is stiffer. If it is too horizontal, it is elastic or less stiff. So based on these concepts, let us see how the graph length and graph diameter is important. So in the first graph, the graph diameter, we have doubled it. We have increased, suppose the diameter, we are comparing the 5 mm graph with a 10 mm graph. So what changes in this? The stiffness changes. If you see, the slope is 2x more in a thicker graph. However, the length remains the same, because if you see the femoral and tibial attachment site, the length is the same. So the elongation failure length is the same. However, the stiffness is 2x more. This second graph is very important, which is often overlooked. We always calculate and see how much is the force to failure in newtons, but we overlook this length aspect. So if we take two equally thick grafts of equal diameter, and if we change the length between the femoral and tibial attachment sites, the stiffness drastically changes. So in the first diagram, the length is suppose x, and if we increase the length to 2x, the stiffness reduces by half. So this is a very important concept in the sense that if we change the femoral or tibial attachment sites, if we make the tibia too anterior or make the femur too posterior, we are increasing the length of the graft. So if even if we use a 10 mm, 11 mm, 12 mm, we are reducing the stiffness of the graft. So that's why these attachment sites are so important. The third important concept is the quality of the graft, whether we are using a parallel fiber grafts or a crisscross grafts. So if we see equally thick graft, suppose and one is a parallel fiber like our ACL, MCL, and if we use a crisscross graft, suppose we use capsules as a graft, the stiffness drastically changes. So even if the diameter is equally thick, if we use a crisscross graft, the stiffness is very low, it is more elastic. And the same can be seen in the lower diagram where we are comparing the MCL with the capsular structures. The stiffness of the capsular structures being crisscross is very low, it is more elastic. And hence the slope of this stress strain graft is drastically reduced. The next important concept which is often overlooked that I have mentioned is the attachment sites. Why it is so important, which you are going to learn today and tomorrow. This is the reason for this. So in these diagrams, let us go one by one. In the first diagram, the plus mark is the attachment site on the femur. On the tibia, we are changing the attachment site. So the M is medial tibia, lateral tibia, anterior tibia. +1, +2, +3, +4, +5. So +1, 3, 5 are more medially. +2, 4, 6 are more laterally. So even if we err on the tibial side, if you see the graphs, there is not much change in the fiber length. The fiber length is pretty much the same. So if you want to err on one aspect, we can err on the tibial aspect for the fiber length. But there are other problems like notching, flexion deformities, other problems are definitely there. But the fiber length remains the same if we err on the tibial attachment sites. But we should not take home this message that we can err on the tibial attachment site, but the fiber length remains the same. But if we shift to this right diagram, if you change the position of the femoral tunnels from anterior to posterior, see the drastic change in the fiber length. So we are absolutely, if we err on this aspect of the femoral ACL attachment site, we are changing the stiffness of the same diameter graft drastically. That's why it's so important to absolutely perfect and to be absolutely accurate in the femoral attachment site anteroposteriorly. If you err from superior to inferior, still it is slightly forgiving. It's not that bad like your anteroposterior erring, but still this is forgiving. Still there is a change in the fiber length. So one take home that we should from this talk, that we should be absolutely accurate in the femoral attachment ACL tunnel locations. Coming to the graft options, we all know what we generally use here is autografts. We are not using the allografts. There's a quadriceps patellar bone graft, there's a hamstring tendon grafts, there's a patellar tendon bone grafts. So based on this stress strain plots, a lot of studies have happened and they have calculated the load to failure and stiffness. So to just conclude from this graph, we can safely say that the quadriceps and the patellar tendon bone is the stiffest compared to the native ACL. However, the hamstring, suppose we do a 4-strand or 5-strand or 6-strand, those the stiffness is low, the load to failure is the highest compared to the native ACL. The native ACL has a load to failure of around 2,100 newtons, but the stiffness of the quadriceps and the patellar tendon bone is the highest. So if we compare these graphs anatomically, so we have seen the load to failure, we have seen the stiffness, but the surface area is also very important. How much surface area we are able to replace. So if we see the surface area, the quadriceps tendon surface area is the highest. That's why it has come in, more and more people are using it because the surface area of the graft is the highest. The surface area of the patellar tendon bone is the lowest. The hamstring graft, the advantages is we can use a 4-strand, 5-strand, 6-strand based on the person. But the disadvantage is sometimes we get a too thin graft, sometimes we get a too thick graft. That's why the thickness is the limiting factor. Coming to the biomechanics, we have already seen that the quadriceps and patellar tendon bone is the stiffest, and the hamstring has the maximum load to failure. The graft incorporation, obviously the bony aspect will have a better incorporation, so patellar tendon bone or quadriceps tendon bone will have a better incorporation than the hamstring tendon graft. So one take home that you should take from this CME is to accurately place your femoral and tibial attachment sites. We should not overlook it. We should be absolutely precise in these points. Thank you, sir.